be looking at Session 8, Acid-Base Imbalance, or Acidosis and Alkalosis. This session seeks to discuss acid-base imbalance. Acidosis and alkalosis are two serious imbalances that, when taken for granted, or if not addressed promptly, can be life-threatening, especially in the newborn. And this session will introduce students to respiratory acidosis and alkalosis, and metabolic acidosis and alkalosis. The goal and objectives are that at the end of this session, students will be able to define metabolic acidosis and alkalosis, and the cause, signs and symptoms, and nursing intervention. The key topics to be covered in this session are metabolic acidosis and alkalosis, and all that we have said earlier on, including nursing management. So once again, any pediatric textbook that addresses this can be used to further enhance your understanding. Acid-base balance. When we talk about acid-base balance, it helps us to assess the adequacy of respiratory functions in the baby. So its key components of blood gases are the hydrogen ion concentration, which is the pH, the partial carbon dioxide concentration, the partial oxygen concentration, and the bicarbonate. Regulation of acid-base equilibrium. Some parameters that you need to note: that the pH in the arterial blood has a normal range between 7.38 to 7.45. In the venous blood, it is 7.35 to 7.45. Partial concentration of carbon dioxide, on the other hand, is 35 to 45 in arterial blood and 45 to 50 in venous blood. Bicarbonate is 23 to 27 and then 24 to 25. So pH. The normal pH, as said earlier, is 3.5 to 4.5 in venous blood. And the pH below 3.5, we said as acidity, the pH decreases, the acidity increases. So in this case, it indicates acidosis, and when it is above 7.5, the alkalinity increases, and it indicates alkalosis. Partial carbon dioxide. It is also very important to know that carbon dioxide, or partial carbon dioxide, is a respiratory component. So it reflects a balance between the production of carbon dioxide and its elimination. So we have said that the normal value is 35 to 45. So carbon dioxide, when it's more than 45, it is acidosis, alkaline in nature. So when it rather decreases, then it becomes alkalosis. And when it increases, it becomes acidic. And then oxygen. Partial concentration of oxygen, normal value 60 to 80. When it decreases, when it is less than 60, it indicates hypoxia, and also connotes that the carbon dioxide level is high. So we said the normal value for oxygen is 60 to 80, and when it is less than 60, it indicates hypoxia, and carbon dioxide has high increases. So it has an inversely proportional relationship with carbon dioxide. And then oxygen, when it is more than 80, it also indicates hyperoxemia, and carbon dioxide levels are lower. Bicarbonate is metabolic in nature, so that has to do with the GIT. So you have normal ranges between 20 to 34. So when it is more or than 24, it indicates alkalosis. And when it is less than 20, it indicates acidosis. So now we're looking at physiology of acid-base balance. Respiratory acidosis is a clinical disorder that characterizes low arterial pH, less than 7.36, an elevation of carbon dioxide, what we call hypercapnia, as we discussed earlier, because of the inverse relationship. When the oxygen concentration goes high, the carbon dioxide goes low, and the inverse is true. And that is what we see in respiratory acidosis. So now we want to go to acid-base imbalance. So for our foundation blocks, it is for us to know that respiratory is acidosis, and it can also be alkalosis, or we can have respiratory acidosis as well as respiratory alkalosis, as I explained earlier, and we can have metabolic acidosis and metabolic alkalosis depending on the shifts. So once again, we are saying that respiratory acidosis is typically caused by reduced breathing and ventilation. So you may see this in patients with asthma, emphysema, chronic bronchitis, and brainstem depression. And respiratory acidosis, on the other hand, you will be seeing in patients with CNS function problems that will show some form of confusion and deterioration, which can also result in coma. Respiratory alkalosis, on the other hand, is also acidic base disturbance and is characterized by elevation in arterial pH. So hyperventilation results in low partial concentration of carbon dioxide. So respiratory alkalosis is typically caused by increased breathing and ventilation. I think everything as we go in is very self-explanatory. So it is also for us to remember that respiratory compensation occurs very fast, within 12 to 24 hours, and the metabolic compensation is rather slow. So it may take days, up to about a week. So the picture of a tiger connotes very fast, and we all know that the tortoise is slow. So metabolic acidosis, as we have seen, there is some excessive loss of bicarbonate and excessive accumulation of hydrogen ions, hence acidosis, because there is high concentration of hydrogen ions. And so you have the reverse in metabolic alkalosis. And this may be caused by increase in acid metabolites, such as lactic acid. And then metabolic alkalosis, as we have said earlier on, is increase in blood bicarbonate, especially in the compensation of acid base, sodium, potassium, and diuretic disorders. In summary, we are saying that respiratory acidosis is carbonic acid excess. Respiratory alkalosis is carbonic acid deficit. Metabolic acidosis is bicarbonate deficit, and metabolic alkalosis is bicarbonate excess. So this is very self-explanatory. So in assessment, you have to look at the history, physical examination, and then also we have to also look at the cavity, the eyes, and all these other indicators. Other laboratory investigations that are also helpful are the hemoglobin and the hematocrit indices. And also overhydration will reduce the hematocrit by dilution. And then you have urine pH and serum albumin levels also decreasing. So we have immature kidneys as one of the main key factors that brings these about, and it is self-explanatory as you read here. And then the fluids and electrolytes balance, we're also saying that another thing is that the surface area. We said that the infant has great surface area due to body mass. So the surface of their bodies, in comparing it to their weight in terms of muscle and organ development, the surface area is bigger. So they tend to lose a lot of fluid. And also this goes with insensible loss that also attracts along the loss with some electrolytes. So once again, the surface area, we are saying that infants with fever will also have greater fluid loss and sweating in older children. And also children are also prone to illness that are involved with fluid loss and fevers. So metabolic rates. Infants generally have high metabolic rates, which makes replacement of water and electrolytes an important issue. Given an already high metabolism, in addition to illness like fever and infection, causes them to produce increased waste, because when the child has high fever, the heart rate increases, the respiratory rate increases, and all these goes with some insensible loss of fluid, and it also goes along with electrolytes, and large amount of waste is accumulated. Proportionally, we're talking about total body water. Infants and small children have greater percentage of body water. We have said that earlier, that the newborn has about 97%, and then the adult may have 60%. So in the adult, we said that is because they lose it tissue loss. So we are saying here that the total body water in the infants and children are higher, which is replaced by fat and muscle as they grow old. Until about the age of 2, half of the total body water is extracellular. So anything that causes depletion of this fluid can be fatal. So infections, diarrhea, and the like, and any other febrile condition can, if left untreated, can be fatal. Infants and children are prone to illness that increase water loss. So it's very, very important that we note this in our care. Intake and output is something that we need to monitor strictly, because children's intake and excrete are larger amounts of fluid proportional than the older child. So because of this, the daily exchange of extracellular fluid is high in the infant, and there is little fluid reserve. Dehydration during vomiting and diarrhea, and as a result of some drugs intake quickly, because there is smaller reserve of fluid, so it easily depletes it. So it's very, very important that we monitor this and then identify any deficit quickly so that it will be addressed immediately. Illnesses that promote fluid loss, we have diarrhea, because we know that during diarrhea, diarrhea can cause dehydration, electrolyte imbalance, metabolic acidosis, as we can see. And this is more likely to be due to the immature system. Vomiting is also one. Causes of vomiting are diagnosed by history, because children also try to learn a lot from their environment by putting their behavior of putting everything in their mouths. Therefore, predispose them to a lot of conditions that promote vomiting and diarrhea. So we have types of dehydration: isotonic, hypovolemic shock, and then hypotonic dehydration. So the causes, as we have said earlier on, are diarrhea, vomiting, and then also it's very, very important that we note that in our setup, in cases where we give children large amounts of water without electrolytes to replace diarrhea, will further worsen the condition and predispose them to dehydration. because of the action of osmosis. And giving IV solutions without sodium will also, to patients who are nil per hours, will also predispose them to dehydration. So, and also enemas that are tap water also will predispose. So today, a more appropriate enema to give will be saline enema. And then hypertonic dehydration. There is a greater loss of water, there is greater water loss and electrolytes. And this is also due to insensible loss from the skin due to respiration and sweating, and then clinical conditions that deplete the body water. So we have looked at fluid management. We have said that in calculating fluid replacement, it is important to note that the first 10 kilograms weight of the child is multiplied by 100, the second kilogram is multiplied by 50, and the remaining 10 by 25. So this is how we calculate. So for example, as you can see on the slide, a baby who weighs 8 kilograms will receive 800 ml of fluid in 24 hours, whereas a child that weighs 15, the first 10 will be multiplied by 100, and then the second 10 by 50. So you have a total of 1,000 plus 250, which will give us a total of 1,250 ml per day. So try your hands on some weights and look at how the fluid is calculated, so that when you come into contact with any child, you can also estimate this. So oral rehydration. Children who are not experiencing illness tend to drink enough and respond to test cues adequately to prevent themselves from becoming dehydrated. So if a child is not sick, while they take enough water, they are okay. But illnesses that tend to make children more prone to dehydration and electrolytes, we have said fever. So here, the metabolic rate increases 10% with every 1 degree Celsius increase in temperature, and 3 to 5 times during shivering, increasing oxygen fluid and caloric requirements. So we have to understand that this is a bit devastating to an ill child and worsens their condition. So we have to put in measures to control some of these things. And then elevated temperature in children also need oral fluids to further rehydrate them and prevent them from dehydration and electrolyte imbalance. So other illnesses that predispose them, cystic fibrosis, diarrhea, and poorly controlled diabetes that results in polyuria. Now we want to look at the management. Oral rehydration is recommended for mild to moderate dehydration. The goal of oral rehydration is gradually increase the fluid with small amounts, even if it's a tablespoon every minute. This allows the child to get used to the fluids and decrease the chance of vomiting. The replacements with small amounts can get absorbed before they get stimulated to vomit, so it helps. Fluids used orally rehydrate the children electrolyte-based and are common guides to follow. There are common guides to follow. We all know this. And then use the oral rehydrating solutions, ORS, as we have on our markets for this preparation, because we know that water alone predisposes them to dehydration. Children who are vomiting can be given 5 to 10 cc every 1 to 5 minutes so that the fluids can be absorbed without stimulating vomiting. So small amounts. So a tablespoon, 2, every 1 to 5 minutes will go a long way to prevent dehydration, and continue to feed normal diets. Thus, if it will improve weight gain, and serve small frequent feeds that the child can tolerate. Also, in management, we have to avoid the following. Diarrhea should not be managed by encouraging clear fluids by mouth. Example, fruit juices, carbonated drinks, all these we are saying that have high carbohydrates content but very low electrolyte content. And the problem at stake is electrolyte imbalance. And that is what is fatal. Caffeinated soda is avoided because caffeine is mild diuretic and may lead to increased loss of water and sodium. This is very important to note. Banana, rice toasted, or tea is contraindicated for a child, especially child with acute diarrhea, because this diet has little nutritional value, low energy and protein, high in carbohydrates and low in electrolytes. All we are emphasizing is that when we have diarrhea, the key, and vomiting and all the other conditions that promote fluid loss and electrolyte imbalances, oral rehydration is the most preferred. So this is where we end our lecture. Thank you very much.